This is a virtual conference, which means there's no need to leave early to catch a train. My name is Sjuve, and I chair the Royal Surrey NHS Foundation Trust, a medium-sized integrated trust comprising community health services, secondary and tertiary cancer care in Guildford. And I'm delighted to be chairing this session on the role of provider boards and committees in tackling health inequalities as a system. Now, you'd think Guildford was a comparatively affluent area and perhaps not overly bothered by health inequalities. That's not so. Life expectancy in Guildford varies by 12 years from one side of town to the other. There are pockets of deprivation, and deprivation is a major factor in health inequalities right across the country. So it's everyone's business. And we will all have heard the stat that only 20% of health outcomes are affected by health service provision. The rest is down to demographics, geography, lifestyle, and social class. So most of it's been determined before we even see a patient, hasn't it? What can providers do, let alone their boards and committees? Well, first of all, we're not just talking about health providers anymore. We're now all part of integrated systems with local authorities, housing associations, and the voluntary sector. And secondly, 20% is not to be sniffed at. So let me introduce our panel. Peter White is chair of North West Ambulance Service, and before that was a NED on the board for several years. In his executive career, he was Lancashire Police Assistant Chief Constable. And as chair of an ambulance trust, he's uniquely well positioned to observe what all the other players in the system are up to and how effective they are. Patricia Miller is Chief Executive of Dorset ICS, responsible for overseeing complex health services and improvement programmes for 800,000 people living in Dorset. Formerly CEO of Dorset County Hospital, she has a strong track record of leading transformational change and is passionate about diversity, inclusion, and health inequalities. Dorset is a great place to retire, and unfortunately, that can make it a bit hard for local young people to find homes. And Babu Bhattacherjee is Director of Communities and Neighbourhoods at Poplar HARCA, a housing association in the east of London, founded by Lord Andrew Mawson. Poplar HARCA is the landlord of about 9,000 homes in East London. A quarter of its homes have been sold leasehold, and the remainder are let on assured tenancies at subsidised rent levels. Babu has 30 years' experience working in a range of community, voluntary and regeneration organisations in London and Manchester, and is joined today by GP Helen Jones for this session. Each speaker is going to take about 7 or 8 minutes to outline for us their insights into this subject, and then we'll open the discussion up for all of you. And if questions occur to you while our speakers are talking, please type them into the chat. So let me turn first to Patricia. Patricia, would you like to share your thoughts on how provider boards and committees can tackle health inequalities as a system?
Thank you, Susan. I'm a bit nervous about being referred to as an expert on the panel, but let's just hope I know something that will be useful to everyone. I've been the Chief Executive of the Dorset Integrated Care System since the 1st of February. A lot of that time spent setting up the new organisation. But I think my starting point would be that systems don't exist in their own right. They are a collection of partner organisations that come together with a shared purpose to deliver for communities. So the role of providers within that, whether they are NHS, third sector or private sector providers, is incredibly important, as well as how we work with business. So if we think about the beginning of integrated care systems, and they were established to remove the traditional barriers between services so that people can access support and the care they need when they need it. What we've done up until now is work in a collaborative way. What the legislation does is put more legal weight behind that, particularly the element changes to the provider licence that talks about the obligation to collaborate in the best interests of communities. And when I think about the objectives that have been set for ICSs, I think that, when we talk about enhancing productivity and improving access and experience, for me, those are a given for the NHS. The two really important elements that are different that we really need to galvanise our collective efforts around are around tackling health inequalities in outcome and a broader inequalities that we can support with, and the NHS being seen as a as a really key partner to the broader and social economic development, which is really key to tackling the wider inequalities in systems that lead to poor health outcomes. Next slide, please. So do we know health inequalities are avoidable? They're down to a whole range of issues that quite often are systemic or institutional, but also about our bias and the lens through which we view the world and particular individuals. And I think there's a really unhelpful thought process going on in the UK at the moment, which is highlighted in the media today, which is people are poor, and that's their own fault, and it's not down to the way that society operates or system and structures that keep them in that place over generations. And when Bevan introduced the NHS, the cross-party view was that it would exist to reduce health inequalities, and if it did its job, that it would not exist for very long. And over 70 years later, we're still here. So I think that tells us something about the way the service has developed. Next slide, please. So for me, why is collaboration critical? And this is where partners and providers come in. Well, it's important because no single health or local government partner can do this alone. It requires collective effort if we're really going to tackle wider inequalities in society. Collaboration provides the opportunity to build strong and successful partnerships, and integrated care systems have the ability to create the perfect conditions for that, to make sure that the change we make for communities that enables them to live their best lives is sustainable in the long term. And I've talked a little bit about the structure and the advantages that brings, and the legal duty to collaborate. Next slide, please. Governance and decision making, really important to support the new way of working. So two layers of governance within ICS is the Integrated Care Board, which is predominantly health partners, and the Integrated Care Partnership, which is the wider partnership that brings in local government, third sector and others. And the ICBs have a very specific role here to work alongside providers to deliver. The Constitution provides the foundation. It outlines what the ICB is here to do and how it will work with partner organisations. The provider regulation needs to include not just the achievement of constitutional standards, which is predominantly where the regional relationship is focused in the regulation of the provider market, but it also needs to move up a gear, I think, into a much more strategic, mature conversation with providers around their contribution to wider inequalities and how they use their anchor institution principles and actions in order to deliver on that. And then the final thing for me is it brings local flexibility. Place-based partnerships and provider collaboratives are key to the delivery. You know, the collaboratives focusing on what should and would be delivered at system level, and then place-based partnerships really embedding themselves in communities and co-designing solutions with them. And again, providers are a really important part of those discussions. Next slide, please. And then the ICPs, again, have some important elements that correspond with that. The development of the integrated care strategy that needs to focus on communities and how ICSs will support them to live their best lives. And partners need to be involved in those conversations and the development of that strategy, because they'll be the key delivery arms for it. Strong link between place and health and wellbeing boards, because health and wellbeing boards have a statutory responsibility. And when we start to think about place conversations, the solid line of accountability in terms of driving that change at place level, of which providers will play an important role, should that place of driving change should sit very firmly with health and wellbeing boards. And then finally, the citizens approach, the true partnership with communities is vital if we're going to implement solutions that are really going to remove the barriers for them to improving their overall health and wellbeing. Next slide, please. For me, local communities are absolutely pivotal to this, and how system-wide we engage with communities, but also really importantly, how we engage with communities at a provider level. The health and wellbeing of local communities is the responsibility of all partners, and how we achieve long life expectancy from cradle to grave and maximise the healthy years starts with an understanding of the root causes. So that's about providers and partners moving away from what has traditionally been a very paternalistic view to community health, telling them what their needs are, telling them what drives poor health, and also then telling them what the solutions are. It requires a different approach, and that approach should be focused on core co-designing solutions by bedding ourselves deeply into communities and understanding what drives inequality and what some of the solutions are. Next slide, please. And when we talk about developing the integrated care strategy and engaging our partners, including communities, to support healthier lives, that care and provision then needs to be seamless when it's required. So it requires us within provider organisations to listen to communities with openness. It requires us to embrace people's lived experience in its purest sense and to get to the root causes of poor health and well-being. It means that all partner strategies have to be reflective of the integrated care strategy if we're all going to move forward with a shared purpose. And it also means that board assurance frameworks need to highlight the key strategic risks and associated mitigations, and to support decision-making with regular scrutiny at committee and board level to make sure that health inequalities really are being addressed and it's a core part of provider business. Next slide, please. And then finally, for me, there's something about the leadership ask at every level, not just at the top of providers, but at every level within there. It requires us to lead differently in terms of skills, to work in collaboration and partnership. It requires us to think about leadership at provider level and system level through the lens of third order change. How do we need to be different as leaders to deliver this? What is required of us? It requires a deep understanding of ED&I, because that sets the foundation for understanding the drivers for health inequalities. And it also sets the foundation for having been able to have conversations with marginalised communities about what really impacts on them with confidence. It needs to be less transactional, more transformational, high degrees of emotional intelligence, competency, and clear communication and engagement. And it needs leaders who can manage complexity both horizontally and vertically in relationships and to have really deep listening skills. Next slide, please. So for me, those are some of the principles around how we work as providers coming together in systems that really will move the health inequalities question forward. And I'm happy to obviously engage in any questions later on in the session. Thank you.
Thank you very much, Patricia. I don't think you need to have any qualms about being described as an expert in this area. I think that comes across from what you've shared with us, and also your passion for the subject. So thank you very much. I'm going to move now to our next speaker, who is Peter. But can I just remind the audience that if you have got any questions, do type them into the chat, and colleagues will order them up for us to answer after everybody has spoken. So Peter, could you go ahead now and share your thoughts with us?
Thank you very much, and hello everyone. I don't have any slides, so you'll be listening to me, and I'll be reading some of my notes. So it'll be a bit of a gallop, but hopefully you'll get something out of it. So, Chair's view as a chair of a provider trust, Northwest Ambulance Service regional, we have 3 full ICSs and 2 part ICSs on our patch, just for a bit of context. So for 2 years we've been, dealing with COVID as everybody else has, and that has made us very tactical as a board. We've been into the detail around response time to look at the big strategic issues that face the service and face ICS development. But one of the things that COVID did do for us is tell us something that we already knew, which is that there are massive health inequalities across the Northwest region. And as Susan has said before, around Surrey, equally in the Northwest, within a matter of less than 10 miles, you can expect to live 10 or more years longer than people that live in more deprived areas. The Marmot Review told us this back in 2010. So here we are some time later, still discussing it and realising just how important it is to our communities and the services that we provide. Now, there's going to be obviously more developments around this, as Patricia just talked about, around how we integrate with the ICSs. But for now, I just want to give you a few thoughts and examples of what we're doing at NWAS to try and breathe some life into health inequalities and what it means for board, for governance, and for non-executives in particular. So I guess the first question is, are health inequalities actually being discussed at board in any detail? or are we diverted by other major pressures such as, ED performance, elective recovery, ICS developments, etc.? It's really difficult to let some of these critical issues sort of filter to the surface so as we get some board time. I'm going to have to switch my video off because I think my bandwidth, hopefully that's going to be a bit better. So that bit there was about, are we actually even discussing this at board? And I would offer, from a personal perspective, we're probably not talking about it as much as we should. But we are having the conversations, but are we as comfortable in that space as we are around talking about our other more traditional performance indicators and risks, etc.? So do we have the skills around the table, such as public health? And have we got the data to support assurance and improvement? Can we cut our data by gender, ethnicity, postcode? Can it be analysed and assessed alongside other key partners like local authorities, housing associations, etc.? So that can develop our board insight and commission work towards improvement and then gain assurance. And again, I would say, from a personal perspective, we've had some very early, drafts of performance and intelligence around what's being done by our service and in the wider ICSs, but it's still nowhere near as developed as it needs to be for us to make really good decisions around health inequality. So that is something that we continue to work at. So having said all that, what can we do as board members? Well, it's been mentioned already that drivers for health inequality, 20% is around healthcare and 80% is around these social determinants. So unashamedly, I'm going to go for the big number and talk about the role of organisations as anchor institutions. So as I said before, NWAS is regional. I've got about 6,000 staff. We operate out of 130 bases across the northwest, and some of those bases are in the most deprived areas of England. So my role really is to ensure that board focuses on those three key areas around health inequalities, which is sustainability in the green sense, employment and professional development, and procurement. So on sustainability, your green plan, how important is it to you as a board? How important and how much scrutiny does it get through your relevant committees? We know that research shows that air pollution, for instance, contributes to cases of asthma, cancer, heart disease, and the NHS contributes about 3.5% of all road traffic pollution. The ambulance service, as you would expect, drive large, very smoky vehicles around these communities every day, hundreds of thousands of miles every year. So decarbonisation for us as a board is really important. So we need to make sure that our vehicles are as efficient as possible whilst understanding the operational impacts on the service. So we aim to cut business mileage by 20%. Another benefit out the back of COVID is we don't do people driving many miles for meetings across the region anymore. But also we need to make sure that 90% of our fleet are low emission vehicles by 2028. That's a massive ask and it's going to cost an awful lot of money, but we know how important it is that we play our part in sustainability. Around the issue of employment and professional development, I think this is where we've made some real inroads. How do we widen access to us as an employer from communities and individuals from not only deprived areas, but disadvantaged and underrepresented groups? So the board needs to see evidence of positive action on recruitment and the development of individuals. We need to see data and case studies, as well as taking the opportunity to speak to our staff networks and patient and community representatives. We've done an awful lot around apprenticeships, and this has been a real success for us. So we've upskilled 83 staff from our patient transport service into our emergency service. And people that join the patient transport service would never really consider a career on the clinical side of the business, but through using apprenticeships and support around numeracy and literacy that we do within the organisation, we've managed to take people through into those clinical roles, which is a real success story for us. And we had a staff story at board. We alternate between patient story and staff story. We had a staff story where a gentleman had gone from patient transport through to the paramedic emergency service and used that route through apprenticeship and degree programme with support. And it's really great to see. So we really need to make sure that we are using all the tools we've got as an organisation to get into communities that wouldn't normally feel that there was a career in the NHS for them. We also, as a side, we have a step into health programme with the military, because we recognise again that military veterans sometimes find it really difficult to assimilate back into communities, and they can go the wrong side of society and end up with no housing, etc. So we make sure we've got a programme for military veterans to come into as well, and we scrutinise how effective and how well those initiatives are performing. We know there's a massive overlap here with EDI, and I haven't got time to go into that now, but ensuring that our organisation reflects the communities we serve is massive for us, but it does line up very much with health inequalities. Finally, on procurement, we've got an 85 million spend on goods and services. It's really important that our resource committee makes sure that we're delivering the 10% social value weighting as we're required to do, but also that we're using local businesses where we can for goods and services, because it's really important that that large amount of cash is spent within the region where it can be. I apologise, that was a bit of a gallop, and I apologise that my bandwidth wasn't right. I'm very lucky to live in a very rural part of Lancashire where unfortunately the internet is pretty rubbish, but it's been a challenge for 2 years, so hopefully it's coming to an end. But any questions, I'm happy to answer. Thanks very much.
Peter, thank you very much. I sympathise with the bandwidth problem. I find my bandwidth is better at home than it is in the trust, but that's another story. Thank you very much for broadening out the discussion there to take in a lot of other subjects about the NHS as an employer, the NHS as a creator of unhelpful emissions and other subjects. So I'm going to turn now to Babu and Helen for their perspective. Do go ahead.
Thanks, Sue. I wanted to start by telling you a bit about Poplar, where we're based. So that's a part of London. We're in the borough of Tower Hamlets, and we're about a quarter of Tower Hamlets. And for about 200 years, we've been one of the poorest, if not the poorest parts of the country, and certainly of London. We still have the highest levels of child poverty. And when we started, we're a relatively young organisation. We're about 22 years old. But when we started, I think there was a clear sense that we had to take a long-term view. We had to work with the local community, and we had to gain their confidence. And Poplar is an amazing place. The people I meet there are fantastic, some of the best people in the world. And we had to kind of represent that properly in our work. And I think from a governance perspective, it was really important that we had a resident majority on our board. And that's how we started. We've still got the largest proportion of our board being local residents. And that's really important because the solutions exist within our community, the skills exist within our community, expertise exists within our community. And so we've got to do that. And so our approach has really been shaped by that. And so even though we've got programs, we've got regeneration programs, we're rebuilding homes, we're building parks, we're building health centres, but our board and our governance is still locally rooted. And I think where we started was that people often, even though there are experts around them, they wouldn't trust those experts. They would trust the local solution rather than an expert one that came from another place. So we had to really learn about that community, what that community was about, and how we could work within the personality of the community that we're part of. And so that's been a 20-year journey, and that journey really needs to be respectful of the community, to understand how it works, but also recognise that if we don't change things, then we've failed as an organisation, we've failed as what we do. Health is part of everything we do. Health is a key issue for us, and we address it in different ways. We start from a great point. We work with the Bromley by Bow Centre, who were the pioneers of social prescribing, of healthy living and healthy living centres. And we've taken those principles and we work collaboratively with the health sector, but also with local residents to create something different. And the point for us is put communities at the heart of what you need to do, put individuals who you might not think of as experts in that role. So we've got youth workers playing a key role in young people's health, and I really want to sort of introduce Helen in a second to talk more about that. We've got GPs working with community workers to really build around well-being and going upstream and developing those services, and really putting inequality and tackling inequality at the heart of everything we do. I really want to give you a specific example of this and talk about our work with young people and young people's health, and how we've worked with local GPs to do that, how we've worked with local health providers to do that. And so I'll hand over to Helen to tell us a bit more about that experience and what we did.
Thanks, Babu. Very, very briefly, the youth provision that's been born out of HARCA approached me about 5 years ago with a simple ask. They'd identified a lot of the challenges that young people were facing in accessing health in its traditional structures, and therefore consequently had a lot of unmet health needs that were escalating and resulting in crisis admissions and youth violence, etc., etc. So what began was a journey to collate further youth voice with different agencies, talking to the local young people, and it all resonated with what was being said at national level. It was in line with Marmot principles, and all basically the ask was an integrated system in action at a local level. So there was a lot of challenge, but with me going to commissioners of mental health, physical health, saying it doesn't sit with us, it sits with, it's a broader system thing, but no one commissioning structure exists to currently allow this to be in action. So what we've done is, for now, we've got a youth clinic, a GP youth clinic sited alongside public health commission services for sexual health and substance misuse, all within the fantastic setting of the youth provision called Spotlight. The absolute key is that the youth workers are there supporting the local young people. They are already known by the youth workers. They know their families, they trust them, they speak like them, they have had similar experiences. And so the young people trust them, and therefore they are more likely to trust me. And what happens is we have fantastic access and engagement, but also we can facilitate them and support them navigating what is actually a very complex system. It's not actually a new thing. We're reconfiguring what's already out there and bringing it into a safe space where young people feel able to be. I'm aware of time, Babu, so I could talk more, but I'll...
Well, I was going to say, I mean, part of the thing that we wanted to do here was bring those individuals that were trusted by young people into the health loop, so that we could really start to make sense of what was happening with young people and providing that kind of input. It put youth workers in a key role alongside GPs. We invested money. So there's a key thing for us that we're a housing provider. Our money comes from rents, from people in social housing. As Sue was saying, we've got about 10,000 properties, but it's investing that in things that we know will make a difference to the local community. Our key things are never quick, they're never cheap, and they're never easy. As Helen says, it's a journey that took 5 years. It took another 5 years to find the right partners, to build the professional expertise. We're linking the IT systems through EMIS so that the records can work in a youth setting. We're investing in the facilities so that it's CQC compliant, that we've got all the things in place. We've got young people in a strong governance role so that they're really bringing those elements together. So you start to see some of the elements that are really working kind of in harmony to create a kind of environment where actually young people are able to thrive and able to come up with issues, and we're starting to shape the wider system now. So now investment is starting to go across East London along these same lines of working with youth providers and GPs and clinical commissioning groups, so that all of these elements are really kind of combining to make the maximum difference. And we're seeing fantastic outcomes for young people. So it's really that principle of building on success, of never giving up, of keeping things going in the long term, and kind of waiting for opportunities and waiting for the right people. And I think that's the system that, as a board, as an organisation, that we really wanted to introduce to you and hopefully commend to you. And I think that's it from us.
Babu, thank you very much, and to you too, Helen. Excellent timekeeping from everybody, which means we've got plenty of time for a Q&A. And I think you've all introduced really interesting points there. I was particularly interested in the point about encouraging young people to be involved in governance and putting them in governance roles. That's certainly something that I've felt tremendous benefit from as a trust chair, having young governors, because they do bring a completely different perspective. So let's move then to our question and answer session. I'm delighted to see that we do have some questions already. Let's kick off with a first question from Swanjit Singh, and it's quite a long question, so I'm going to read this out. What are the system levers that NHS England and Improvement can take to really support boards in health and care systems, including those of provider alliances, to make a transformation in outcomes for both our patients and staff? For example, boards are routinely measuring and reporting on differentials in waiting lists our boards routinely measuring and reporting on differentials in waiting lists by ethnicity and the steps they're taking to address them, waiting times for assessment for children with learning disabilities. And I'm going to suggest that Peter might like to come in on that first, and then others. Peter, since you mentioned that in your presentation.
Yeah, thanks, Susan. Well, I can speak from, obviously, as an ambulance chair, but I do sit in the system meetings with chairs from acutes, and from a Northwest perspective, I don't think that's as refined as we would all want it. Now they are, comparing and sort of looking across their patch at elective waiting times around ED performance, cancer performance, etc. So they are looking at how they can, sort of minimise that. But whether that's being done through the lens of inequality, I don't think they're there yet. And I'm speaking from a Northwest perspective, but they are certainly having those conversations now as we prepare to move to the ICS in July. They're having those conversations about, as a system, how they can do that better. There's one particularly, I think it's Cheshire and Mersey ICS, who have got a hub system for looking at performance across these big areas that we're all worried about. And I think within that, it's up to chairs and chief executives to press for far better understanding of the health inequality lens on those hubs, to see if there are any patterns that are coming out around certain areas, from certain communities that aren't getting the same level of service as others. So it is being talked about, but I think yet to see the detail on the proper data analysis of it. Analysis is key to this, Susan, from my point of view. I think, having come from outside the NHS, one of the things the NHS has got a lot of is data, got masses and masses of data. I don't think the NHS is as good at analysing that data and understanding what the problems are, but that's a personal view. But I think that's where ICSs can really take this forward.
I agree. I think ICSs can add some value in analysis and insight, in terms of selecting actions that we take, because there always seem to be so many things we could do, and it's narrowing it down to those things which are going to be most effective and focusing on those, isn't it? Patricia, that's a good cue to ask you from the ICS perspective, if you've got a comment on that question.
I think there are a few things. I think that the first issue for me is the data and the access to the data, as Peter said. And I think I'm really fortunate in our system. We were a population health management pilot site. So we've got a very, very sophisticated system and data set that we're helping the rest of the South West region to roll out. So I think that's one of the things that the centre can really help with, is how providers develop their capability around being able to disaggregate all their data between ethnicity, gender, and deprivation, right down to neighbourhood GP practice level. I think there's something around how we then use that information and supporting the principle of equity of access, not equality of access, because equity of access is a different principle, and that's about agreeing the way that we tackle inequalities along the lines of Michael Marmot's views around proportionate universalism and accepting that differential investment will be needed in different areas, and that more socially mobile affluent communities will need different types of access than those that are deprived and can't access service easily. So I think there's something about agreeing that principle. I think the third element is encouraging boards to see all of their service delivery, particularly the restart and restore of services post-COVID, through that health inequalities and social value lens. Because if we don't start that process now and we restart services in the old way that we've been doing it, then we're perpetuating the old problems. The next step for me is when we think about elective recovery, not doing what we've done in the past, which is cohorting solutions in a way that affluent communities will take advantage of and deprived communities won't. So thinking very differently. And then I think the final thing is reflective of a national meeting that I was in a couple of weeks ago with Amanda, which is how we publish the next version of the long-term plan and taking our sight away from the old transactional target approach to service delivery and homing in on a small number of priorities that are really important to our communities, that don't just tackle the inequalities issue, but also start to bring down NHS spend, because currently it occupies 40% of tax receipts. We can't carry on like that. So if we, as an example, really put our efforts behind as a national system, tackling things like type 2 diabetes and the issues around that, and they're more particularly prevalent in marginalised communities, then we'll also start to bring NHS spend down and being able to focus our pounds in other areas that are just as important.
Thank you very much, Patricia. We've got a couple more questions, so can I just check whether Babu and Helen wanted to respond to that, or shall I move on to the next question?
No, I don't think we wanted to add much. I mean, just that from our perspective, I think having social justice at the core of a lot of these discussions is really key. But yeah, only that really.
Thank you. In fact, the next question I think is probably one that you will want to take first, and it's a question from Pauline Lambert. And Pauline asks, can you describe and share how the young people are used in a governance role?
Well, I can start off and Helen can chat through as well. So a number of different levels. So we've had young people on our board throughout our existence, and that's been really helpful. We have a specific board for young people. So we have a youth empowerment board who are made up of young people around the area. And then specifically, we'll have young people who've been involved in the health spot service that Helen runs, also contributing to priorities, and it's all based on kind of a system of talking to young people, getting information, and then translating the information to a service, and then getting regular feedback on how that service runs, and then also that regular track back to groups of young people that we're working with over a period of time. But I'll let Helen sort of talk more specifically as well.
Thank you. Yeah, and I mean, just to add into that, I think what was really striking for me coming in at the start of the journey was that actually, as people are saying, there's actually quite a lot of data out there, but I think particularly for young people, often it will be the more resilient, eloquent people that may have been able to contribute to the consultations. And so what's been fascinating with this journey is that we've got youth workers as the trusted adult. Often a lot of these young people don't, their families are not necessarily a safe space. They have that relationship of trust. So the youth worker may be representing them, especially initially, or other providers that work with vulnerable young people. So it's really important to capture that as well. And I think in terms of, from a health perspective, certainly primary care, we've been getting unique insights because of that trusted relationship with the youth worker about the difficulties they have in access to a system that is just so tricky to navigate. Anybody in the room that's tried to get a GP appointment may also be nodding their heads right now. Just add in the fact that the main online consultation provider in England has not allowed under 18s or under 16s more recently to access it themselves digitally. There's so many examples. So what we've been able to do is take that voice, which is so loud and clear, and actually not just apply it to our own little model, but actually it's been amplified and shared at North East London, and also there's been a lot of national interest, which is been fantastic. But we want it to translate to change. That's the challenge.
Thank you, Helen. That's great. Patricia or Peter, would either of you like to comment on involving young people in governance? Do you have anything to add?
I just think from MWAS's point of view, obviously we're not a foundation trust, so we haven't got governors, but we set up just before COVID a patient and public panel, because we're very conscious that particularly young people don't have a voice into the governance system at NWAS. So we've concentrated on recruiting younger people into that group, and it's been absolutely fantastic. I mean, they attend board meetings as observers, but importantly, when we're pre-governance meetings, when we're bringing out new policies, procedures, or different services that we're looking at, or how we might deliver services in certain areas, they're a really strong voice in giving us feedback on those policies and procedures at a time when before they're actually implemented, which is really, really important, because I think, again, historically, we've probably implemented things and then thought after, oh, we should really talk to some members of the community and patients about this. So it's really good that we're getting that upfront input, not only from young people but from other diverse members of the community, which again, historically, certainly for North West Ambulance Service, we've struggled to recruit non-executives from different communities. So it's good that we're having far more success in the patient and public panel, and there's like 3 tiers to that. You can have as much involvement or as little. You can just be told what's going on, or you can go all the way through to advising on policy and procedure. And we've got a good range of both age groups and ethnicities on all those stages. So that's really good for us.
Thank you, Peter. That's really helpful. Patricia, did you want to add?
Just a small comment. So at my last organisation, provider, we really struggled to recruit young people to the Council of Governors. So we chose to go in a different route, and we started a young volunteers service for people from 16 to 25. And it was one of the best things we ever did, because it enabled us to get their views into service provision. We already had a really good co-design approach for young people with learning disabilities, but we wanted to get the wider community, and it also gave them a different view about careers in public service. So it was a really beneficial, and it gave them a different view about citizenship. And now that I'm in the ICB, we're just in the process of developing a proposal for a shadow board with young people to help them understand how decisions are made, and also to give their feedback to the actual board meeting. And this morning we've had a workshop looking at how we improve the way that we provide anticipatory care to our frail population, so that we're intervening much further upstream to prevent them going into long-term care and maintain their independence for as long as possible. And actually, one of the decisions we've made this morning is that we're going to recruit some young people into that service to be the ones that interview elderly and frail people to complete the initial questionnaire about their lived experience, because it will give them a different view about ageing, and it will give them a different view about what citizenship and cohesion of communities is all about. So I think they are absolutely key, because they're the key to the future, and if we don't get it right for them, then we're going to repeat the mistakes that Marmot talks about all the time.
Thank you, Patricia. I love that idea of having a young people shadow board on the working with the ICB. I think I'm going to shamelessly pinch that and suggest that in Surrey Hartland. So thank you very much. The next question that we have is from Jonathan Devling, and he asks, apart from working on being an anchor institution and having achieved social value recognition, does the panel have any thoughts on the role of specialists or tertiary providers? So who would like to kick off on that one?
I probably do. So I think if we think about tertiary providers as opposed to single specialist providers, I think they've got a dichotomy of how do you concentrate on your expertise in terms of the tertiary centre, which is very internally focused a lot of the time, as well as for the DGH arm of the organisation, how do you maintain that outward focus to engage in the ICS in the broadest sense? And I think that's a real challenge. But what I also think is that there is still something about the way that clinicians view individual patients, and even at the specialist end, they tend to view them as the disease that they present with, as opposed to in a more holistic way about understanding the journey to sometimes getting that specialist condition if it's not something that you were born with. And then what's the contribution then to the health inequalities question? And how do you signpost patients into a broader set of support? And I think all providers have to go through that journey, whether you're specialist or not, because the days of us seeing people as a single disease and taking a single lens view of them as opposed to a more generic view about a whole range of package of support that they might need, I think those days are gone. And I think we've all got to think very differently in the world of ICS is about how we provide patients and communities with that broad range of support and not through that single lens.
Thank you, Patricia. Thank you very much. I'm going to try and squeeze one last question in, and perhaps this one is being aimed at Peter. I think you mentioned, Peter, that you have a patient and public panel, and Pauline Lambert asks or says she would be really interested to know more about your patient and public panel. And since we have only 4 minutes to go, I wonder if you could distill that into 2 minutes worth for us.
I'll do my best. Well, Pauline, it's basically there's a process. It's advertised for applying to become a member of the patient public panel. It's clearly stated, what the amount of time we expect and what the role entails. And like I say, there's 3 stages to it. The top stage being very, very much involved and very close to us around policy and process development and scrutiny, because they attend board meetings. And they have an opportunity to ask questions of the board at the end of board meetings, all the way through to just being kept up to date with what's going on in NWAS. I think last time we had an update on it, we've got about 200 members of that patient and public panel, and specifically, the direction from board was that we wanted a really great cross section of people from all parts of the Northwest, particularly from underrepresented groups and particularly from young people. So the comms team that pull all that together, made sure that the advertisements were on Medium that would attract applicants from that. So we made a lot of use of social media to get young people involved. It's no good talking to somebody like me about social media, but we have got people in it that's that are experts that really know how to engage with people through it. So it's been very, very effective for us. And equally, when now COVID is finished, we will start going out as board members, and we have community meetings across the Northwest where non-executive members go, and part of that process is to recruit people for the patient and public panel. If they're interested, we give a bit of an update. It takes some personal commitment from the non-executives, because I think that link between patient and public panel members and the non-executive is very important. So we always go to their meetings, we always go to the recruitment events to make sure that we show support for them in it, and we make a point of supporting them after board meetings if there's any questions that they don't understand. But we get an awful lot back from them, and things that I remember. Just one very quick example: I had some people from the deaf community that came along to some of our meetings, and immediately it was very obvious to everybody that we just were not aware, of the things that we needed to do to make our meetings more accessible to deaf people. To make our services more accessible to deaf people, things like 111, 999 telephony, etc. So whilst we had some things in place, we've improved it significantly as a result of the feedback from that community, which we would never have got without the patient and public panel.
Perfect timing, Peter. Thank you very much indeed. That was really helpful. I have to say, I think this has been a really worthwhile discussion. Lots of really interesting material that our audience can follow up. If I had to pick out a few key points, I think it would be the importance of providers embedding themselves in the local community and co-designing with them rather than telling them what they need. I think this topic is as broad as it is deep, and with system providers' roles as employer and as a green or not so green business, and as a partner in the provision of health and wellness, as well as a provider of their main service business. And finally, really struck by the contribution that young people should be encouraged to make to the development of patient-centred, community-centred holistic health services. So thank you very much for all of that. That's been incredibly helpful. And just as this is the last session of the conference, I'd really like to thank our three speakers, well, four speakers, in fact, because Helen's joined us, Patricia, Peter, Babu, and Helen, for all the thought and preparation that went into this session. Also our colleagues at NHS Providers, who've been typically professional and imaginative in choosing the programme for this conference and in supporting the chairs and contributors to the 12 sessions. And finally, I'd like to thank all of those of you in the audience for your attention and participation. Please don't forget to complete the participants survey so that next year's governance conference can be even better. And on the dot of 4 o'clock, good afternoon and goodbye.